RN-Link presents Outpatient CDI Fundamentals and Advanced Practice by Anne-Marie Gould and Christy Zielinski. If you would like to earn CEUs, this presentation offers continuing education units for a fee. The program is approved by the Board of Registered Nursing and accepted by the Association of Clinical Documentation Improvement Specialists and the American Health Information Management Association. Otherwise, you are welcome to watch the video for educational purposes. Learning objectives. Upon completion of this webinar, participants will be able to 1. Define the role and scope of outpatient CDI. 2. Differentiate inpatient and outpatient CDI workflows. 3. Identify documentation opportunities affecting risk adjustment and HCC capture. 4. Apply compliant outpatient query practices. 5. Recognize common documentation deficiencies impacting reimbursement and quality metrics. 6. Review outpatient CDI opportunities across major specialties. 7. Understand CMS, ICD-10-CM, and risk adjustment requirements. 8. Develop strategies for successful outpatient CDI program implementation. Disclaimer: this presentation is intended for educational purposes only and does not constitute legal, clinical, coding, billing, reimbursement, or compliance advice. Participants should verify all information using current CMS guidance, ICD-10-CM official coding guidelines, payer policies, and their organization's policies and procedures before applying it in practice. Some content may have been developed with the assistance of artificial intelligence, AI tools, and has been reviewed by the presenter. Because healthcare regulations and coding guidance change over time, attendees are responsible for independently validating all clinical, coding, regulatory, and reimbursement information using official sources. References to CMS, AHIMA, ACDIS, and other organizations are for educational purposes only and do not imply endorsement of this program. Introduction to Outpatient CDI. Why outpatient CDI matters. Healthcare reimbursement increasingly depends on risk-adjusted reimbursement, quality outcomes, value-based care, physician performance metrics, population health management, accurate disease burden reporting. Let me discuss each items on why outpatient CDI matters. Risk-adjusted reimbursement. Many reimbursement models, including Medicare Advantage and other value-based contracts, adjust payment based on the documented complexity of a patient's health conditions. Complete and specific documentation ensures that chronic conditions, disease severity, and comorbidities are accurately captured through hierarchical condition categories, HCCs, and other risk adjustment methodologies. Underdocumentation can result in lower reimbursement and an inaccurate representation of patient complexity. Quality outcomes. Healthcare organizations are increasingly evaluated on patient outcomes rather than service volume. Documentation directly impacts quality measures by accurately reflecting patient severity, comorbidities, complications, and expected outcomes. Incomplete documentation may make patient outcomes appear worse than they actually are. Quality measures affected include hospital readmissions, mortality rates, preventive care compliance, chronic disease management, patient safety indicators, patient experience measures. Value-based care. Value-based care emphasizes delivering high-quality, cost-effective care while improving patient outcomes. Payment models reward providers for achieving quality benchmarks, reducing unnecessary utilization, and effectively managing chronic diseases. Documentation serves as the clinical evidence supporting these performance measures. Examples include accountable care organizations, ACOs, Medicare Shared Savings Program, MSSP, bundled payment models, commercial value-based contracts, Primary care incentive programs. Physician performance metrics. Provider documentation contributes to individual and group performance evaluations. Many organizations incorporate documentation quality into physician scorecards and compensation models. Complete documentation improves coding accuracy, quality reporting, and demonstrates the complexity of patients being treated. Performance measures may include risk-adjusted quality scores, documentation completeness, HCC recapture rates, MIPS performance, clinical quality measures, coding accuracy. Population health management. Population health focuses on improving outcomes for groups of patients by proactively identifying and managing chronic diseases and health risks. Accurate documentation allows healthcare organizations to identify high-risk populations, allocate resources appropriately, and coordinate preventive and chronic care services. Effective documentation supports chronic disease registries, preventive care initiatives, care management programs, high-risk patient identification, resource planning, health equity initiatives. Accurate disease burden reporting. Documentation should accurately reflect the patient's true clinical complexity and the resources required to manage their care. Disease burden reporting influences reimbursement, quality benchmarking, organizational planning, and public reporting. When diagnoses are incomplete, nonspecific, or unsupported, organizations may underestimate the complexity of their patient population. Examples of documentation opportunities include diabetes with chronic kidney disease instead of diabetes, chronic systolic heart failure instead of CHF, COPD with chronic respiratory failure instead of COPD, stage 4 chronic kidney disease instead of renal insufficiency, morbid obesity instead of obesity. The bottom line. Outpatient CDI plays a critical role in ensuring that clinical documentation accurately reflects the patient's health status. High-quality documentation supports appropriate risk-adjusted reimbursement, reliable quality reporting, success in value-based care programs, accurate physician performance measurement, effective population health management, a true representation of disease burden and resource utilization. As healthcare continues its shift toward value-based reimbursement, outpatient CDI has become a strategic investment that benefits patients, providers, and healthcare organizations alike. CDI evolution. Traditional CDI focus are 1. MSDRGs 2. CC and MCC capture 3. Inpatient denials prevention. Modern CDI focus are 1. HCC capture 2. RAF scores 3. Quality reporting 4. Ambulatory documentation 5. Physician practice support. Let's further explain the traditional and modern CDI focus. Traditional CDI focus. Traditional CDI programs were primarily designed to improve the accuracy and completeness of inpatient documentation, ensuring that hospitals received appropriate reimbursement for the care provided while maintaining compliance with coding and regulatory requirements. 1. MSDRGs. Medicare Severity Diagnosis-Related Groups. What are MSDRGs? MSDRGs are the inpatient hospital payment system used by Medicare and many other payers. Each inpatient admission is assigned to an MSDRG based on principal diagnosis, secondary diagnoses, procedures performed, presence of complications or comorbidities, CCs and MCCs, patient discharge status, Each MSDRG has a predetermined reimbursement amount intended to reflect the expected resources required to care for patients within that group. Traditional CDI goal. The primary objective was to ensure documentation accurately reflected the reason for admission, severity of illness, resource utilization, complexity of care. Accurate documentation supported correct MSDRG assignment, appropriate hospital reimbursement, compliance with coding guidelines. Example: incomplete documentation, pneumonia. Improved documentation, aspiration pneumonia due to dysphagia following prior ischemic stroke. This added specificity may affect MSDRG assignment and better represents the patient's clinical complexity. 2. CC/MCC capture. What are CCs and MCCs? They are secondary diagnoses that can significantly impact MSDRG assignment. CC, complication or comorbidity, a condition requiring additional evaluation, treatment, or monitoring that increases resource utilization. Examples: acute blood loss anemia, hyponatremia, moderate malnutrition. MCC, major complication or comorbidity, a more severe condition associated with greater clinical complexity and higher expected resource use. Examples: acute respiratory failure, severe sepsis, acute kidney injury, septic shock. Traditional CDI goal. CDI specialists reviewed records to identify clinically supported CCs and MCCs that were not fully documented by providers. Common documentation opportunities included acute respiratory failure, acute blood loss anemia, severe protein-calorie malnutrition, encephalopathy, acute tubular necrosis, sepsis. Why it matters. Capturing clinically supported CCs and MCCs improves reimbursement accuracy, reflects true patient severity, supports severity of illness (SOI) and risk of mortality (ROM), improves quality benchmarking. 3. Inpatient denials prevention. As payer audits increased, CDI expanded its role beyond reimbursement optimization to ensuring documentation could withstand clinical validation and coding audits. Common reasons for denials: unsupported diagnoses, lack of clinical indicators, insufficient medical necessity, incorrect principal diagnosis, missing documentation, coding errors. Traditional CDI activities: concurrent chart review, clinical validation, physician queries, documentation clarification, collaboration with coding, denials prevention. Goal: create a complete, clinically supported medical record that accurately reflects the care delivered and supports appropriate reimbursement. Now let's discuss the modern CDI focus. Healthcare reimbursement has shifted from paying primarily for services provided to rewarding organizations for accurately documenting patient complexity, managing chronic diseases, and achieving positive outcomes. As a result, CDI has expanded into outpatient and ambulatory settings, where documentation influences reimbursement, quality metrics, and population health. 1. HCC capture, hierarchical condition categories. What are HCCs? HCCs are used in Medicare Advantage and many value-based payment models to estimate expected healthcare costs based on documented chronic conditions. Unlike MSDRGs, which apply to a single inpatient admission, HCCs reflect the patient's overall disease burden across the year. CDI goals: Ensure providers to document chronic conditions annually. Specify disease severity. Link associated complications. Address conditions during the encounter. Support diagnoses with clinical evidence. Examples: instead of diabetes, document type 2 diabetes mellitus with diabetic chronic kidney disease, stage 3B. Instead of CHF, document chronic systolic heart failure. The impact for accurate HCC capture are: improves reimbursement accuracy, reflects patient complexity, supports care management, enhances risk adjustment, reduces audit risk. 2. RAF scores, risk adjustment factor. What is the RAF score? The RAF score estimates the expected healthcare costs for an individual patient based on demographics, chronic conditions, disease severity, HCCs. Higher RAF scores indicate greater expected healthcare needs. Why RAF matters? Accurate RAF scores help ensure providers caring for medically complex patients receive appropriate reimbursement and resources. CDI responsibilities. Review prior year HCCs, chronic disease documentation, annual recapture opportunities, clinical support for diagnoses. Benefit of accurate RAF scores: support population health, resource allocation, value-based reimbursement and quality benchmarking. 3. Quality reporting. Documentation now affects far more than reimbursement. It also influences publicly reported quality outcomes and provider performance. Examples of quality programs are Merit-Based Incentive Payment System, MIPS, Medicare Shared Savings Program, MSSP, Medicare Advantage Star Ratings, Accountable Care Organizations, ACOs, and commercial value-based contracts. Documentation influences readmission rates, mortality, preventive care, chronic disease management, patient safety, and clinical quality measures. CDI goal: ensure documentation that accurately reflects disease severity, comorbidities, clinical decision-making, and patient complexity. This helps create fair comparisons among providers and organizations. 4. Ambulatory documentation. Modern CDI extends beyond the hospital to physician offices, specialty clinics, emergency departments, observation units, ambulatory surgery centers, and telehealth. The focus shifts from documenting a single hospitalization to managing patients over time. Key areas are chronic disease management, preventive care, annual HCC recapture, longitudinal documentation, medication management, and follow-up care. Documentation should describe current disease status, stability or progression, response to treatment, ongoing monitoring, and clinical decision-making. Benefits of strong ambulatory documentation are: improves continuity of care, supports coding accuracy, enhances quality reporting, strengthens risk adjustment. 5. Physician practice support. Modern CDI emphasizes partnership rather than retrospective review. CDI specialists work closely with providers to improve documentation quality while minimizing administrative burden. Support activities are specialty-specific education, documentation tip sheets, one-on-one coaching, real-time feedback, EHR template optimization, query assistance, and documentation performance dashboards. Benefits to providers. High-quality documentation accurately reflects patient complexity, supports medical necessity, improves coding accuracy, enhances quality scores, reduces audit risk, and supports value-based payment. CDI specialist's role. Today's CDI professional is an educator, collaborator, and clinical documentation expert who partners with physicians, coders, quality teams, revenue integrity, compliance, and population health to improve documentation across the continuum of care. This slide compares traditional versus modern CDI at a glance. Traditional CDI focus. Inpatient hospital focus. MSDRG reimbursement. Acute inpatient encounters. CC and/or MCC capture. Concurrent chart reviews. Denials prevention. Hospital payment accuracy. Modern CDI focus. Outpatient and inpatient continuum. Value-based reimbursement. Longitudinal patient management. HCC capture and annual recapture. Concurrent prospective and retrospective reviews. Risk adjustment, quality, compliance, and denials prevention. Population health and organizational performance. Key takeaway. Traditional CDI centered on accurate inpatient reimbursement through MSDRGs, CCMCC capture, and denials prevention. Modern CDI has expanded to support the entire healthcare continuum by improving HCC capture, RAF score accuracy, quality reporting, ambulatory documentation, and physician practice support. This evolution positions CDI as a strategic partner in advancing value-based care, improving patient outcomes, and ensuring documentation accurately reflects the complexity of the patients served. This slide shows outpatient CDI settings, hospital-based and outpatient-based CDI. Outpatient settings for CDI includes physician practices, primary care, family medicine, internal medicine. It also includes specialty clinics like cardiology, pulmonology, oncology, neurology, endocrinology. While hospital-based outpatient CDI includes emergency department, observation, same-day surgery, infusion centers, wound clinics. Foundations of outpatient CDI. Core goals. To improve. 1. Documentation specificity. What is documentation specificity? Documentation specificity means recording the most precise and complete diagnosis supported by the patient's clinical condition. Rather than documenting broad or nonspecific diagnoses, providers should document the exact disease, severity, acuity, associated conditions, and any complications. Specific documentation allows coders to assign the most accurate IC10-CM codes and ensures the medical record truly represents the patient's condition. Why it matters. 1. Improves coding accuracy. 2. Supports medical necessity. 3. Reflects patient complexity. 4. Reduces coding queries. 5. Enhances communication among healthcare providers. 6. Decreases audit risk. Here are the examples of nonspecific documentation and specific documentation. Nonspecific documentation. Diabetes, kidney disease, pneumonia, anemia. Specific documentation. Chronic systolic heart failure instead of CHF. Type 2 diabetes mellitus with diabetic neuropathy instead of diabetes. Chronic kidney disease stage 4 instead of kidney disease. Aspiration pneumonia due to dysphagia instead of pneumonia, and iron deficiency anemia secondary to chronic blood loss instead of anemia. CDI focus. CDI specialists help providers document laterality, acuity, acute versus chronic, severity, cause and effect relationships, disease manifestations, associated complications, to severity capture. What is severity capture? Severity capture ensures that documentation accurately reflects how sick the patient truly is and the complexity of managing their condition. Two patients may have the same diagnosis, but require very different levels of care based on disease severity. Why it matters? Capturing severity reflects the intensity of services provided, supports appropriate reimbursement, improves quality benchmarking, accurately measures patient complexity, provides context for clinical outcomes. Examples: instead of COPD, document severe COPD with chronic hypoxic respiratory failure requiring continuous home oxygen. Instead of heart failure, document acute on chronic combined systolic and diastolic heart failure. Indicators of severity: disease stage, complications, organ dysfunction, oxygen dependence, functional limitations, frequency of exacerbation, response to treatment. CDI role. CDI specialists identify opportunities to clarify disease severity, clinical significance, complications, manifestations, acute versus chronic conditions. 3. Chronic disease reporting. What is chronic disease reporting? Many outpatient visits involve the management of chronic conditions rather than acute illnesses. Accurate documentation of chronic diseases is essential because these conditions often affect patient outcomes, resource utilization, risk adjustment, and long-term care planning. Unlike inpatient documentation, outpatient CDI focuses on the patient's ongoing health status throughout the year. Why it matters? Many chronic conditions require annual documentation, influence HCC capture, affect risk adjustment factor scores, guide care management programs, support population health initiatives. Common chronic conditions: diabetes, chronic kidney disease, heart failure, COPD, asthma, coronary artery disease, depression, morbid obesity, dementia, hypertension. When clinically relevant. CDI focus. Ensure documentation reflects current status, disease progression, ongoing treatment, monitoring, clinical assessment, response to therapy. Documentation should demonstrate that chronic conditions are actively addressed during the encounter rather than simply listed on the problem list. 4. Quality scores. What are quality scores? Healthcare organizations and providers are increasingly evaluated based on quality measures rather than the volume of services delivered. Documentation plays a critical role in accurately measuring patient outcomes and provider performance. Why it matters? Quality scores influence provider performance evaluations, public reporting, value-based reimbursement, shared savings programs, incentive payments, hospital and physician rankings. Examples of quality program: Merit-Based Incentive Payment System (MIPS), Medicare Advantage Star Ratings, Accountable Care Organizations, ACOs, Medicare Shared Savings Program, MSSP, Commercial Value-Based Contracts. Documentation supports chronic disease management, preventive care, readmission reduction, mortality measurement, patient safety indicators, clinical quality measures. CDI role. CDI specialists help ensure documentation accurately reflects patient severity, comorbid conditions, clinical decision-making, expected outcomes, appropriate care provided. This helps ensure providers are evaluated fairly based on the complexity of the patients they treat. 5. Risk adjustment. What is risk adjustment? Risk adjustment is a methodology used to account for differences in patient complexity when comparing healthcare costs, outcomes, and provider performance. Patients with more severe or multiple chronic illnesses are expected to require more healthcare resources than healthier individuals. Accurate documentation ensures reimbursement and quality comparisons reflect the patient's true health status. Why it matters. Risk adjustment affects Medicare Advantage reimbursement, value-based payment models, population health programs, resource allocation, care management, and performance benchmarking. Documentation requirements. Risk-adjustable diagnoses should be clinically supported, documented annually, when applicable, addressed during the encounter, supported by assessment and management. CDI focus. Review documentation for missed HCC opportunities, disease specificity, chronic condition recapture, clinical validation, and appropriate linkage of related diagnoses. Example: instead of diabetes, document type 2 diabetes mellitus with diabetic chronic kidney disease, stage 3B. This documentation more accurately reflects patient complexity and supports appropriate risk adjustment. 6. Compliance. What is compliance? Compliance means documentation and coding accurately reflect the patient's clinical condition while adhering to federal regulations, coding guidelines, payer requirements, and organizational policies. The goal is to ensure that every reported diagnosis is truthful, clinically supported, and appropriately documented. Why it matters. Strong compliance practices reduce audit risk, prevent overcoding and undercoding, support accurate reimbursement, promote documentation integrity, and protect providers and organizations from regulatory penalties. Documentation should never report unsupported diagnoses, include conditions that were not evaluated or managed, rely solely on copied or cloned documentation, assign diagnoses based only on abnormal laboratory values or imaging results, add diagnoses solely to increase reimbursement. CDI role. CDI specialists promote compliance by validating clinical indicators, issuing compliant provider queries, educating providers on documentation requirements, supporting accurate code assignment, and collaborating with coding, compliance, and quality teams. Key takeaway. The 6 core goals of outpatient CDI work together to ensure the medical record tells the complete and accurate story of the patient's health. By improving documentation specificity, capturing disease severity, reporting chronic conditions, supporting quality scores, enhancing risk adjustment, and maintaining compliance, CDI professionals help healthcare organizations deliver better patient care, improve performance in value-based payment models, reduce audit risk, and ensure appropriate reimbursement. Key differences between inpatient versus outpatient CDI. Inpatient. DRG focus. Acute conditions. Single encounter. CC/MCC capture. And hospital reimbursement. Outpatient R. HCC focus. Chronic conditions. Longitudinal care. RAF accuracy. Provider reimbursement. Documentation requirements. Documentation should support assessment. Documents the provider's clinical judgment, diagnosis, and current status of the patient's condition, example, stable, improving, or worsening. Clinical relevance. Shows that the diagnosis is clinically significant and affected the patient's care, medical decision-making, or treatment plan during the encounter. Monitoring. Demonstrates ongoing observation of the condition through symptoms, vital signs, laboratory results, imaging, or follow-up evaluations. Evaluation. Includes interpretation of clinical findings, review of diagnostic tests, assessment of treatment effectiveness, or reassessment of the patient's condition. Treatment. Documents interventions such as medications, procedures, referrals, counseling, therapy, care planning, or other actions taken to manage the condition. Remember, a documented diagnosis should be supported by the provider's assessment and the care provided during the encounter. Complete documentation helps support coding accuracy, medical necessity, risk adjustment, and quality reporting. The MEET criteria. Supporting chronic condition documentation in outpatient CDI. The MEET criteria is a widely recognized documentation framework used to demonstrate that a chronic condition was actively addressed during an outpatient encounter. While CMS does not officially mandate the MEET acronym, many healthcare organizations and Medicare Advantage plans use it as a best practice to support risk adjustment documentation and HCC reporting. For a chronic condition to be reported, the documentation should show that the provider monitored, evaluated, assessed/addressed, or treated the condition during the encounter. Monitor. E. Evaluate. Assess. T. Treat. Now let me explain more on the MEET criteria. A monitor. Definition. Monitoring involves observing, tracking, or following the patient's condition to determine its current status or response to treatment. This includes reviewing symptoms, physical findings, laboratory results, imaging studies, or other clinical data. Purpose. Monitoring helps demonstrate that the condition remains clinically relevant and requires ongoing physician oversight. Examples. Reviewing laboratory values, A1C, creatinine, eGFR, BNP. Monitoring blood pressure or blood glucose logs. Assessing oxygen saturation. Reviewing home blood pressure or weight records. Evaluating symptoms such as dyspnea, chest pain, or edema. Reviewing imaging studies, X-rays, CT, MRI, echocardiograms. Reviewing specialist consultation reports. Monitoring medication side effects. Documentation example. Diabetes remains controlled. Review today's A1C of 7.2%. Home glucose log reviewed. COPD stable. Pulse oximetry reviewed at today's visit. Evaluate. Definition. Evaluation involves interpreting clinical findings and determining the patient's condition has improved, worsened, remained stable, or requires changes in management. Purpose: evaluation reflects the provider's clinical judgment and medical decision-making. Examples: reviewing laboratory trends, comparing imaging results, determining disease progression, assessing response to medications, interpreting diagnostic tests, determining effectiveness of treatment, identifying complications. Documentation example: renal function remains stable with eGFR unchanged from previous visit. Heart failure symptoms have improved since increasing diuretic dosage. Repeat echocardiogram demonstrates persistent reduced ejection fraction. Assess or address. Definition: assessment documents the provider's clinical impression of the patient's condition and its current status. It explains how the condition affects the patient's health and often includes the provider's diagnosis or updated clinical judgment. Purpose: assessment demonstrates that the provider recognized the condition as an active medical problem requiring consideration during the encounter. Examples: documenting disease severity, identifying acute versus chronic conditions, determining whether the condition is stable, worsening, or improving, identifying associated complications, confirming diagnoses, discussing prognosis. Documentation example: chronic systolic heart failure remains stable. Type 2 diabetes with diabetic CKD remains controlled. Provider can add the CKD stage to be more accurate. Stage 3B chronic kidney disease without progression. COPD with chronic hypoxic respiratory failure remains oxygen dependent. Treat. Definition: treatment includes any intervention provided to manage the condition. Treatment may involve medications, procedures, referrals, counseling, education, or care planning. Purpose: treatment demonstrates that the diagnosis directly influenced patient care during the encounter. Examples: prescribing new medications, continuing current medications, adjusting medication dosages, ordering laboratory studies, ordering diagnostic imaging, referring to specialists, providing dietary counseling, recommending exercise or lifestyle modifications, performing procedures, developing follow-up plans, coordinating care with other providers. Documentation example: continue metformin and empagliflozin. Repeat A1C in 3 months. Increase Lasix to 40 mg daily. Follow up with cardiology. Referred patient to nephrology for CKD management. This slide is a snapshot of MEET in practice. MEET component. What the provider documents. Examples: monitor, observes or follows the condition, reviewed labs, symptoms, imaging, vital signs, specialist notes, evaluate, interprets findings and disease status, reviewed test results, assess progression, evaluated treatment response, assess, documents clinical impression and diagnosis, stable CHF, worsening CKD stage 3B, recommended to be documented by provider to be more specific, controlled diabetes with neuropathy, treat, manages the condition, medication changes, referrals, procedures, counseling, follow-up plan. Example using MEET. Condition: Type 2 diabetes mellitus with chronic kidney disease. Monitor: Reviewed A1C creatinine and eGFR. Reviewed home blood glucose readings. Evaluate: Diabetes remains well controlled. Kidney function unchanged since previous visit. Assess: Type 2 diabetes mellitus with diabetic CKD stage 3B. Condition remains stable. Treat: Continue metformin. Reinforce diabetic diet. Repeat A1C and renal panel in 3 months. Follow up with nephrology as scheduled. Key takeaway: The MEAT framework helps demonstrate that a chronic condition was actively managed during the encounter rather than simply listed in the medical record. Although every element of MEAT is not required for every diagnosis, documentation should include sufficient evidence that the condition was clinically relevant and influenced the provider's evaluation, medical decision-making, or treatment plan. Consistent use of MEAT supports accurate coding, HCC capture, risk adjustment, medical necessity, and overall documentation integrity. Now let's discuss risk adjustment in HCCs. Understanding risk adjustment in outpatient CDI. As healthcare continues to shift from fee-for-service to value-based care, accurate clinical documentation has become increasingly important. Risk adjustment is a methodology used by CMS and many commercial payers to account for differences in patient health status when determining reimbursement and evaluating healthcare quality. Rather than paying providers the same amount for every patient, risk adjustment recognizes that patients with multiple chronic conditions, significant comorbidities, and greater disease severity require more healthcare resources than healthier individuals. Complete and accurate documentation ensures reimbursement and quality comparisons appropriately reflect the complexity of the patients being treated. For outpatient CDI professionals, risk adjustment is one of the primary drivers of documentation improvement. Let's start with risk adjustment. What is risk adjustment? Risk adjustment is a statistical model that predicts a patient's expected healthcare costs based on documented diagnoses and demographic characteristics. The goal is to ensure providers caring for medically complex patients are compared fairly and reimbursed appropriately. Risk adjustment is commonly used in Medicare Advantage Part C, Medicare Shared Savings Program MSSP, Accountable Care Organizations ACOs, Commercial Value-Based Payment Contracts, Population Health Programs, Quality Benchmarking Initiatives. Without risk adjustment, providers caring for sicker patients could appear to have poorer outcomes or higher costs simply because of the complexity of their patient population. Why risk adjustment matters. Accurate risk adjustment supports appropriate reimbursement, fair provider performance comparisons, better population health management, accurate quality reporting, improved resource allocation, care management planning, financial sustainability in value-based payment models. When chronic conditions are not documented or lack specificity, the patient's disease burden is underestimated. This can result in lower reimbursement, inaccurate quality scores, and missed opportunities to identify patients who may benefit from additional care coordination. Next is HCC. What are hierarchical condition categories, HCCs? HCCs are groups of ICD-10-CM diagnosis codes that represent chronic diseases and conditions associated with increased healthcare costs. CMS uses HCCs to estimate the expected cost of caring for Medicare Advantage beneficiaries. Unlike inpatient MSDRGs, which determine payment for a single hospitalization, HCCs reflect the patient's overall health status throughout the calendar year. Not every ICD-10-CM diagnosis maps to an HCC. Only selected conditions that significantly influence future healthcare costs are included in the HCC model. How HCCs work. Each qualifying diagnosis is assigned to an HCC category with an associated risk weight. These risk weights contribute to the patient's risk adjustment factor score, which helps estimate expected healthcare expenditures. Key principles include: exist annually. Diagnoses must be documented and coded each calendar year. Chronic conditions do not automatically carry over from year to year. The diagnosis must be clinically supported. The condition must be addressed during the encounter. Documentation should demonstrate ongoing management using accepted documentation principles such as meet, monitor, evaluate, assess, treat. Examples of common missed HCC opportunities. Common chronic conditions that frequently impact risk adjustment include diabetes, type 2 diabetes with chronic kidney disease, type 2 diabetes with neuropathy, type 2 diabetes with retinopathy, heart failure, chronic systolic heart failure, chronic diastolic heart failure, acute on chronic combined systolic and diastolic heart failure, chronic kidney disease, stage 3B CKD, stage 4 CKD, stage 5 CKD, end-stage renal disease, ESRD, respiratory diseases, COPD with exacerbation, chronic respiratory failure, oxygen dependence, when appropriately documented. Other common HCC diagnoses: protein-calorie malnutrition, morbid obesity, major depressive disorder, cirrhosis, organ transplant status, amputation status, pressure ulcers, rheumatoid arthritis, Parkinson's disease. Annual HCC capture. Exist annually. Be clinically supported. Be addressed during encounter. Meet criteria. One of the most important concepts in outpatient CDI is annual recapture. An HCC diagnosis documented last year does not automatically count for the current year. Providers must document and address qualifying chronic conditions at least once during each calendar year for them to be reported for risk adjustment. For example, 2025 documentation. Type 2 diabetes mellitus with diabetic CKD stage 3B. If this diagnosis is not documented and addressed during 2026, it generally cannot be reported for 2026 risk adjustment, even though the patient still has the condition. Documentation requirements for HCCs. Documentation should clearly identify the specific diagnosis, current disease status, stable, worsening, improving, uncontrolled, etc., severity or stage, associated complications or manifestations, current treatment plan, ongoing monitoring or evaluation. The documentation should support why the diagnosis remains clinically relevant during that encounter. Common outpatient documentation deficiencies. 1. Problem list cloning. Risks. Unsupported diagnoses. HCC overreporting. Audit exposure. 2. Lack of specificity. Examples: poor, anemia, better, iron deficiency anemia, poor, kidney disease, better, CKD stage 4. 3. Status conditions. Often missed. Amputation status, colostomy status, tracheostomy status, organ transplant status, chronic disease monitoring gaps. Commonly missed. Stable angina, COPD severity, heart failure type, CKD stage, malnutrition, depression severity. Examples of documentation to show the importance of diagnosis specificity. Specific documentation improves coding accuracy and risk adjustment. Less specific. Diabetes, THF, kidney disease, COPD, obesity. More specific. Type 2 diabetes mellitus with diabetic CKD stage 3B. Chronic systolic heart failure. Chronic kidney disease stage 4. Severe COPD with chronic hypoxic respiratory failure. Morbid obesity, BMI documented when appropriate. The role of outpatient CDI. Outpatient CDI specialists partner with providers to improve documentation by reviewing documentation before or after encounters, identifying missing chronic conditions, clarifying diagnosis specificity, educating providers on documentation best practices, supporting compliant query practices, improving HCC recapture. Ensuring documentation supports coding and medical necessity. The goal is not to increase reimbursement by adding diagnoses, but to ensure the medical record accurately reflects the patient's true health status and the care provided. Specialty-specific CDI opportunities. Cardiology. Common opportunities. 1. Heart failure. Capture. Acute. Chronic. Systolic. Diastolic. Combined. 2. Atrial fibrillation. Capture. Paroxysmal. Persistent. Permanent. 3. Coronary artery disease. Capture. Native vessel. Bypass graft. Angina relationship. Next specialty is pulmonary. 1. COPD. Capture. Exacerbation. Severity. 2. Respiratory failure. Capture. Acute. Chronic. Acute on chronic. 3. Oxygen dependence. Document. Home oxygen use. Continuous oxygen requirement. Endocrinology. 1. Diabetes. Capture all manifestations. Neuropathy. CKD. Hyperglycemia. Hypoglycemia. Retinopathy. On nephrology. 1. CKD. Capture. Stage. Dialysis dependence. Associated conditions. Neurology. 1. Stroke history. Document. Residual deficits. Hemiplegia. Aphasia. Dysphagia. On oncology specialty. 1. Malignancy status. Capture. Active treatment. Remission. History of cancer. Key takeaways. Risk adjustment accounts for differences in patient complexity and expected healthcare costs. HCCs are diagnosis groupings used to estimate disease burden in Medicare Advantage and other value-based payment models. Chronic conditions must be documented, clinically supported, and addressed each calendar year to be reported for risk adjustment. Specific, complete documentation improves coding accuracy, supports appropriate reimbursement, enhances quality reporting, and accurately reflects the complexity of the patients receiving care. Outpatient CDI professionals play a vital role in improving documentation quality, supporting providers, strengthening compliance, and advancing value-based healthcare. Outpatient query practice. AHIMA/ACDIS query principles. Queries should be non-leading, clinically supported, clear, compliant. Sample queries. The sample queries included in this presentation are provided for educational purposes only. They are examples of compliant documentation clarification and should be adapted to meet your organization's policies and current coding and regulatory guidance. Diabetes specificity. Clinical indicators. Diabetes. CKD stage 3. eGFR 45. On insulin. Nephrology consultation. Based on your clinical judgment, clinical findings, and documentation, can you please clarify in your progress note or discharge summary the diagnosis associated with these findings? A. Type 2 diabetes with diabetic CKD. B. Type 2 diabetes without complication. C. Other. D. Unable to determine. Always include as many clinical indicators as possible. Examples are lab results, consultation, medications, treatments, etc. Heart failure type. Clinical indicators. EF 35%. Lasix. Cardiology documentation of chronic heart failure. Chest X-ray result is pulmonary edema. Based on your clinical judgment, clinical findings, and documentation, can you please clarify in your progress note or discharge summary the diagnosis associated with these findings? Chronic systolic heart failure. B. Chronic diastolic heart failure. C. Combined systolic and diastolic. D. Other. E. Unable to determine. Always include as many clinical indicators as possible. Examples are lab results, consultation, medications, treatments, etc. Next slides will explain the quality measures and regulatory impact. Quality programs influenced by documentation. MIPS, ACO REACH, MSSP, and Medicare Advantage. Let me explain each of these quality programs. MIPS, Merit-Based Incentive Payment System. What is MIPS? The Merit-Based Incentive Payment System is a CMS value-based payment program for eligible clinicians participating in Medicare. MIPS evaluates provider performance across multiple categories and adjusts future Medicare payments based on overall performance. Performance categories. Quality. Cost. Promoting interoperability. Improvement activities. Why documentation matters. Accurate documentation supports. Quality measure reporting. Appropriate diagnosis coding. Medical necessity. Accurate risk adjustment. Clinical decision-making. Patient complexity. Incomplete documentation may negatively affect a provider's quality score and future Medicare reimbursement. CDI opportunities. Improve diagnosis specificity. Ensure chronic conditions are documented. Support medical necessity. Promote complete assessment and treatment documentation. ACO REACH, Accountable Care Organization realizing equity, access, and community health. What is ACO REACH? ACO REACH is a CMS value-based care model designed to improve care coordination, health equity, and outcomes for Medicare beneficiaries. Participating organizations are financially accountable for the quality and total cost of care provided to their patient population. Primary goals: improve patient outcomes, reduce unnecessary healthcare spending, promote coordinated care, advance health equity, enhance access to healthcare services. Why documentation matters. Clinical documentation directly impacts risk adjustment, patient complexity, quality benchmarks, population health reporting, shared savings calculations. Accurate documentation ensures providers caring for complex patients are appropriately evaluated and reimbursed. CDI opportunities. Capture chronic diseases annually. Improve HCC documentation. Document disease severity. Support care coordination and chronic disease management. Next quality program is MSSP, Medicare Shared Savings Program. What is MSSP? The Medicare Shared Savings Program encourages providers to work together as accountable care organizations to deliver coordinated, high-quality care while reducing unnecessary healthcare costs. Organizations that meet quality and cost-saving goals may share in the savings generated for Medicare. Program objectives: improve quality of care, reduce healthcare costs, prevent unnecessary hospitalizations, improve chronic disease management, encourage preventive care. Why documentation matters. Documentation affects patient risk scores, benchmark comparisons, quality reporting, cost performance, shared savings opportunities. Patients with greater disease burden require more resources. Complete documentation ensures organizations receive appropriate credit for managing medically complex populations. CDI opportunities. Capture all active chronic conditions. Document disease progression. Improve diagnosis specificity. Support accurate quality reporting. Last quality program is Medicare Advantage. What is Medicare Advantage? Medicare Advantage Part C allows beneficiaries to receive Medicare benefits through private health plans approved by CMS. These plans use hierarchical condition categories and risk adjustment factor scores to estimate expected healthcare costs. Payment to Medicare Advantage plans is adjusted based on the documented complexity of their members. Why documentation matters. Every calendar year, providers should document and address active chronic conditions that affect patient care. Accurate documentation ensures the patient's disease burden is appropriately reflected. Documentation influences HCC capture, RAF scores, risk-adjusted reimbursement, care management, population health initiatives, audit readiness. CDI opportunities. Ensure annual HCC recapture. Improve documentation specificity. Link diseases with associated complications when clinically supported. Validate diagnoses using appropriate clinical evidence. Promote documentation that demonstrates ongoing management using accepted documentation practices such as MEET. Key takeaway. Although each CMS program has different goals, they all rely on accurate, complete, and clinically supported documentation. High-quality documentation enables healthcare organizations to accurately represent patient complexity, support appropriate reimbursement, improve quality performance, strengthen risk adjustment, enhance population health management, reduce audit risk, succeed in value-based care initiatives. Note: clinical documentation integrity professionals play a critical role in helping providers document the complete patient story, ensuring both excellent patient care and accurate reporting across these quality programs. Quality metrics impacted by readmissions, mortality, risk adjustment, utilization metrics, and cost scores. Documentation and denials. Common audit findings are unsupported HCCs, cloned documentation, no MEET support, problem list only diagnoses. Recommended outpatient CDI workflow. Step 1. Review the patient schedule. Purpose. The CDI specialist begins by reviewing upcoming outpatient appointments to identify patients who may benefit from a documentation review before their visit. What to review? Daily provider schedules, upcoming annual wellness visits, new patient appointments, follow-up visits for chronic disease management, transitional care visits, Medicare Advantage patient appointments, high-volume specialty clinics. Why it matters. Reviewing the schedule allows CDI specialists to prioritize patients who present the greatest documentation opportunities before the encounter occurs. CDI tip. Focus first on providers and clinics with large Medicare Advantage populations or patients with multiple chronic conditions. Step 2. Identify high-risk patients. Purpose. Not every outpatient visit requires CDI review. Prioritizing high-risk patients helps maximize the impact of limited CDI resources. Patients to prioritize. Medicare Advantage beneficiaries, patients with multiple HCC conditions, high RAF scores, multiple chronic illnesses, frequent emergency department visits, frequent hospital admissions, high-cost utilizers, complex specialty patients, patients with recent discharges, patients with multiple specialists involved in their care. Why it matters. These patients often have significant documentation opportunities that affect risk adjustment, quality reporting, reimbursement, and care coordination. Example: patient with diabetes, CKD stage 4, heart failure, COPD, morbid obesity, may have several chronic conditions requiring annual documentation and ongoing management. Step 3. Review prior year HCCs and medical history. Purpose. Many chronic conditions must be documented every calendar year to support risk adjustment. Reviewing prior documentation helps identify diagnoses that may need to be addressed during the current visit. CDI review includes previous year's HCC diagnoses, active problem list, past medical history, specialist documentation, hospital discharge summaries, laboratory results, imaging reports, medication list, previous CDI recommendations. Questions to ask. Which HCCs were reported last year? Have these conditions been addressed this year? Is the diagnosis still clinically active? Has the disease progressed? Are complications now present? Has treatment changed? Why it matters. Conditions documented last year do not automatically carry forward into the current year for risk adjustment purposes. Reviewing historical information helps identify opportunities for annual recapture when clinically appropriate. Step 4. Review current documentation. Purpose. The CDI specialist evaluates the provider's documentation to determine whether it accurately reflects the patient's current health status, disease severity, and medical decision-making. Documentation review focus. Chief complaint. History of present illness. Assessment and plan. Medication management. Chronic disease status. Laboratory interpretation, diagnostic imaging, medical decision-making, specialist recommendations. Look for specific diagnoses, disease severity, acute versus chronic conditions, associated complications, cause and effect relationships, current treatment plan, clinical evidence supporting diagnoses. Example. Instead of CHF stable, look for chronic systolic heart failure remains stable on guideline-directed medical therapy, with no evidence of volume overload. Step 5. Identify documentation gaps. Purpose. After reviewing the medical record, the CDI specialist identifies opportunities to improve documentation accuracy and completeness. Common documentation opportunities. Missing HCC diagnoses. Nonspecific diagnoses. Missing disease stage. Missing acuity. Missing manifestations. Unlinked related conditions. Unsupported diagnoses. Missing treatment documentation, incomplete assessment, missing medical necessity. Examples. Instead of kidney disease, clarify, chronic kidney disease stage 3B. Instead of diabetes, clarify, type 2 diabetes mellitus with diabetic chronic kidney disease. Instead of respiratory failure, clarify chronic hypoxic respiratory failure requiring home oxygen. Why it matters. Identifying documentation gaps before coding helps ensure the medical record accurately reflects the patient's complexity while supporting compliant coding and reimbursement. Step 6. Communicate with providers. Purpose. Effective provider communication is one of the most important responsibilities of the CDI specialist. The goal is to improve documentation through education and clarification, not simply to generate queries. Communication methods. Concurrent CDI reviews. Real-time messaging within the EHR. Documentation tip sheets. One-on-one provider education. Specialty-specific education sessions, compliant provider queries, documentation feedback reports, department meetings. Best practices. Be collaborative and respectful. Use clinically supported evidence. Keep communication concise. Explain why documentation matters. Focus on improving the medical record rather than reimbursement alone. Reinforce documentation best practices through ongoing education. Example. Instead of saying, "Please document more diagnoses," consider, "The laboratory results in current treatment appear consistent with CKD stage 4. If clinically appropriate, would you consider clarifying on your progress notes the stage of CKD to more accurately reflect the patient's condition?" Note: as per example, I would change the word document to clarify. Step 7. Track outcomes and measure success. Purpose: monitoring CDI outcomes helps evaluate program effectiveness, identify trends, and demonstrate the value of outpatient CDI to organizational leadership. Key performance indicators (KPIs). Productivity metrics. Charts reviewed. Reviews completed per day. Reviews by clinic or specialty. Time per review. Documentation metrics. Documentation improvement opportunities identified. Query rate. Query response rate. Provider agreement rate. Documentation completion rate. Quality metrics. HCC recapture rate. RAF score improvement. Risk adjustment accuracy. Quality measure performance. Medical necessity improvements. Financial metrics. Estimated reimbursement impact. Denial reduction. Audit findings. Revenue integrity improvements. Provider engagement metrics. Provider participation. Education sessions completed. Documentation scorecards. Specialty-specific improvement trends. Why it matters. Tracking outcomes allows organizations to demonstrate the value of CDI, identify educational needs, improve documentation quality over time, support compliance initiatives, enhance value-based care performance, strengthen collaboration between CDI, coding, quality, and providers. Continuous improvement. Outpatient CDI is an ongoing process rather than a one-time review. Successful programs continually evaluate documentation trends, provide provider education, monitor quality measures, and refine workflows to adapt to evolving regulatory requirements and organizational goals. This is the summary of CDI prioritization. High priority. Medicare Advantage. Multiple chronic conditions. High RAF scores. New patients. High utilizers. Case study. These case studies are fictional and provided for educational purposes only. Clinical indicators and sample queries are illustrative and should not be used to assign diagnoses or codes without appropriate provider documentation and clinical support. Always follow current CMS, ICD-10-CM, AHIMA/ACDIS, payer and organizational guidelines. Additional query opportunities may be needed, depending on the available documentation. The examples below illustrate potential query opportunities. History of present illness, HPI. The patient is a 68-year-old male presenting for routine follow-up of multiple chronic conditions including diabetes mellitus, chronic kidney disease, congestive heart failure, chronic obstructive pulmonary disease, and coronary artery disease. He reports mild baseline shortness of breath with exertion, which he states is unchanged from prior visits. He denies chest pain at rest but notes occasional exertional chest tightness that resolves with rest. No recent hospitalizations or emergency department visits. He reports adherence to medications but admits occasional dietary noncompliance with sodium and carbohydrate intake. He continues to use home oxygen at night and intermittently during the day with activity. No acute complaints today. Past medical history. Type 2 diabetes mellitus. Chronic kidney disease, previously noted. Stage not specified in current documentation. Congestive heart failure. Chronic obstructive pulmonary disease. Coronary artery disease. Hypertension. Obesity. Medications. Metformin. Insulin glargine. Furosemide Lasix. Sacubitril/valsartan Entresto. Metoprolol succinate. Atorvastatin. Aspirin. Tiotropium Spire-Eva. Albuterol inhaler PRN. Home oxygen therapy, nocturnal and exertional use. Vital signs. BP 142/86. Heart rate 78. Respiratory rate 18 per minute. SpO2 89% on room air. BMI 42. Physical exam. General. Obese male, no acute distress. Cardiovascular. Regular rate and rhythm. No murmurs, trace bilateral lower extremity edema. Respiratory. Diminished breath sounds bilaterally. No acute wheezes or crackles. Extremities. 1+ pitting edema bilateral lower extremities. Neuro. Alert and oriented ×3. Labs/diagnostics. Hemoglobin A1c 9.4%. eGFR 28. BNP 840. Urine microalbumin positive. LDL 88 mg per deciliter. Assessment. Diabetes mellitus type 2. Poorly controlled. Chronic kidney disease. Severity not further specified in documentation. Chronic systolic heart failure. Clinically stable on guideline-directed therapy. Chronic obstructive pulmonary disease. Oxygen-dependent. Coronary artery disease. Stable with intermittent exertional symptoms. Morbid obesity, BMI 42. Hypertension. Controlled on current regimen. Plan. Continue current heart failure regimen. Entresto, beta blocker, diuretic. Continue insulin therapy. Reinforce glycemic control and dietary adherence. Continue home oxygen therapy. Monitor oxygen saturation. Continue COPD inhaler regimen. Continue statin and aspirin therapy for CAD. Nephrology follow-up recommended for CKD monitoring. Encourage weight management and lifestyle modification. Follow up in 3 months or sooner if symptoms worsen. Query opportunities. Opportunity number 1. Chronic kidney disease. Although I will hold on this until after nephrology has seen the patient so an accurate documentation of the stage can be coded. Current documentation. CKD. Clinical indicators. eGFR 28. Creatinine 2.2. You can also add nephrology consultation on the clinical indicators. CDI provider query template. Clinical clarification request. Chronic kidney disease CKD stage. Dear provider, the medical record reflects documentation of CKD, with supporting clinical indicators including eGFR of 28 and creatinine of 2.2 mg per deciliter. To ensure accurate and complete clinical documentation, please clarify the stage of chronic kidney disease being treated and/or evaluated during this encounter. Query options. Please select 1. Chronic kidney disease stage 1. Chronic kidney disease stage 2. Chronic kidney disease stage 3A. Chronic kidney disease stage 3B. Chronic kidney disease stage 4. Chronic kidney disease stage 5. End-stage renal disease, ESRD. Other, please specify. Clinically unable to determine. Clinical significance. Accurate staging of CKD is important for reflecting disease severity and progression. Supporting appropriate INCM code assignment. Ensuring accurate risk adjustment and quality reporting. Enhancing continuity of care and treatment planning. Thank you for your clarification. I will also wait until I have the succeeding creatinine results. Opportunity number 2. COPD. Current documentation. COPD. Clinical indicators. Home oxygen. SpO2 89%. Byriva. Albuterol. To ensure the medical record accurately reflects the patient's respiratory condition, please clarify the diagnosis that best describes the patient's respiratory status for this encounter, if clinically supported. Please select the most appropriate diagnosis. COPD without respiratory failure. COPD with chronic hypoxic respiratory failure. COPD with chronic hypercapnic respiratory failure. COPD with chronic hypoxic and hypercapnic respiratory failure. COPD with acute exacerbation. COPD with acute exacerbation and chronic hypoxic respiratory failure. COPD with other respiratory condition. Please specify. Other diagnosis, please specify. Clinically unable to determine. Thank you for your clarification. Just remember, the options you provide should be consistent with the medical records. Example: don't include on the option of exacerbation if that is not consistent with the documentations by the providers. Opportunity number 3. Coronary artery disease, CAD. Current documentation. CAD. Dear provider, clinical indicators. The medical record reflects the following. Diagnosis of coronary artery disease, CAD. Current medications are aspirin, atorvastatin, metoprolol succinate. Ongoing outpatient follow-up for chronic cardiovascular disease. Note: additional clinical information such as prior cardiac catheterization, coronary angiography, CABG, PCI/stent placement, stress testing, or cardiology consultation notes may support further specificity. The medical record documents coronary artery disease. To ensure accurate and complete clinical documentation, please clarify the patient's coronary artery disease, if known and clinically supported. Please select the most appropriate diagnosis: coronary artery disease type. Atherosclerotic heart disease of native coronary artery, without angina pectoris. Atherosclerotic heart disease of native coronary artery with angina pectoris. Please specify type of angina if known. Atherosclerosis of coronary artery bypass grafts without angina. Atherosclerosis of coronary artery bypass grafts with angina. Please specify type. Coronary artery disease of unspecified vessel or graft. Other, please specify. Clinically unable to determine. Thank you. Note: the options you provide should be consistent with the medical records. Opportunity number 4. Diabetes type 2 poorly controlled. Current documentation. Diabetes mellitus type 2 poorly controlled. Dear provider, the medical record documents type 2 diabetes mellitus. Clinical findings include an A1C of 9.4%, and ongoing treatment with insulin and oral/other glucose-lowering medications. Based on your clinical judgment and the patient's overall clinical presentation, Please further specify the current status of the patient's type 2 diabetes, if clinically appropriate. Please select the most appropriate diagnosis. Type 2 diabetes mellitus with hyperglycemia, chronic kidney disease. Include stage if known and documented. Type 2 diabetes mellitus, without mention of complication. Other clinical specification. Clinical indeterminate / not clinically significant. Thank you. Educational takeaway. This case illustrates a common outpatient CDI opportunity. Chronic conditions should be documented with the highest level of specificity, supported by the clinical record. Clarifying the type of diabetes, stage of CKD, CAD, COPD allows the documentation to more accurately reflect the patient's health status, supports appropriate coding and risk adjustment, and improves the overall quality and integrity of the medical record. As a reminder, include only query choices or options that are clinically supported by the medical record. Put your knowledge to the test. Ready for a quick challenge? Use the descriptions below to complete the quiz and test your understanding of outpatient CDI. Pause the video at any time if you choose to accept the challenge. Outpatient CDI success depends on strong provider engagement, accurate chronic condition documentation, annual HCC recapture, meet compliance, query compliance, quality measure awareness, continuous education. References: Centers for Medicare and Medicaid Services (CMS), American Health Information Management Association, Association of Clinical Documentation Integrity Specialists, ACDIS CM Official Guidelines for Coding and Reporting, Medicare Advantage Risk Adjustment Model Documentation Guidelines. The answers to the quiz are on the next slide. Thank you for watching. Make sure to click subscribe, follow, and like buttons to stay updated with our latest content. For just $70, you can access 3 hours of continuing education by clicking or copying the link below. To earn your certificate, simply complete the evaluation.